movement, ventilation. Again, ventilation is the mechanical process of air entering and exiting the lungs. That's the easy thing, okay? The internal and external respirations that occur happen at the cellular level, which you've got to understand. You've got to understand that, again, inhalation is an active process, whereas exhalation is not. Okay, so it doesn't take a whole lot of energy for the diaphragm to relax and go back into its current dome shape, and then again, the pressure changes. So initially upon inhalation, the thoracic cavity is negative as far as pressure, and then it turns positive in order for exhalation to occur. Okay, now you have to understand diffusion, because diffusion means that things from a higher concentration goes into an area of lower concentration. We're not talking about active transport. That means that energy, the sodium-potassium pump, for example, requires energy to make that pump happen. This is something that occurs on its own because, again, the principle is that things from a higher concentration go to an area of lower concentration. So when you have the alveoli, and then you have the capillary bed that come in from your arteries and veins, right, before they disperse back out, is that, again, the membrane that's kind of in between this, or actually the lining of the alveoli, is only single cell thick. That allows the free movement of oxygen from the higher concentration, which is here, to go and diffuse into the blood and attach to the protein hemoglobin on the red blood cells so that it can be onboarded and then shot out through the rest of the body. Which also means that carbon dioxide, which is much higher in the veins coming in, that it's going to diffuse outward back into the alveoli so that that can be exhaled as a waste product of cellular metabolism.
Yeah, this stuff was the part we got.
Okay, so what are you having problems with? Because when we come to to what?
Like the equipment and the questions and the layout, at least for me, I'm not sure if anyone else is having the same issue,
Yes.
is how it relates to specific conditions, the exact different rates getting memorized to the point of being able to answer a complicated question with a series of that stuff. So it's all the equipment.
Okay,
The functionality stuff,
so everybody understands functionality.
Yeah.
Okay, well, again, you have to understand the normal process in order to know how to help someone who is requiring the O2 delivery devices at higher concentrations.
Yeah.
Okay, so I kind of gave you an example. So I gave you an example of someone who has an acute myocardial infarction, which is nothing more than a heart attack, right? Keep in mind that we want something greater than 94% when we talk about oxygenation. Specifically, those who's having a heart attack or stroke or something like that, a nasal cannula is going to be about the only thing that we give them to maintain their oxygenation greater than 94%. It has been proven through research that if we give higher concentrations and then they're up at the 99 to 100% range, that's actually going to cause them damage to the heart muscle that we're trying to save. So I gave you an example of an AMI with a nasal cannula. Strokes would be another one. We don't want to overpower them with oxygen because once, especially if the stroke is based on a clot, because once they bust that clot and the arteries that's taken higher concentrations of oxygen on the other side, that can actually damage the tissue to where now what was irreversible comes permanent. Okay, so that's how come we want to give lower concentrations. So when we start talking about patient assessments today and next week, this is all going to come to fruition as far as, okay, well, how much oxygen do I really give? Where can I start? Where do I want to begin? There's always a rule of thumb is that we never withhold oxygenation from someone who needs it. This is not just based on your pulse oximetry, okay, which is this thing right here. I'm sure when y'all go to the doctor, they put this thing on your little finger and then they check your blood pressure at the same time, okay? you have to understand your equipment and you have to understand the limitations of your equipment. Okay, for example, fake fingernails, false reading. Someone who's been exposed to carbon monoxide, false reading. This is a diagnostic tool to help you determine, do I need to give someone oxygenation or not? Patient presentation and your assessment of the patient is what's going to be more important than this machine. Your patient is going to present to you, are they in respiratory distress or are they not? This is an additive tool. It's great for us. Yay. Gives us a number. But again, you also have to understand the limitations of this thing. So, I'll give you an example. So, if you are called to a situation in which someone has, let's say, a cough, cold, fever for a couple of days. We get in there, we start our assessment, we do scene safety, level, general impression, level of consciousness, and she's our only patient, and we're doing an assessment. We start asking questions. Okay, the first 5 never change. 1, we want to know if they're alert and oriented and can they talk to me, because if they're fluently talking to me, I know what? Their airway is open. 2, that they're breathing because they're talking in long sentences or a full sentence before comfortably taking another breath before they continue with their sentence. So those 2 things I've already kind of adjusted to and kind of know, okay, well, they're kind of talking to me and stuff like that. How they present to you, patient position, is going to be important. And I kind of did an over-exaggeration. Are you really concerned that I'm having trouble, difficulty in breathing, like I'm in trouble? Okay, if I'm like, restless, anxious,
leaning forward.
Start asking me questions, I'm going to be totally confused. Okay, so again, you have to pay attention to the entire presentation of your patient. This right here, am I telling you something?
Yeah.
Okay, so again, patient presentation is going to tell you a lot before you start asking questions. So when I'm assessing airway and breathing, they go hand in hand. 1, we have to ensure that the airway is open and patent and clear. How do I know that? I'm talking to the patient. Well, he's talking back to me. He can answer me in full sentences. Am I going to have a little bit of concern if he's able to talk to me in 2 or 3 words before having to take 50 breaths in between before he completes that sentence? Absolutely I am. That's not normal. Then whenever I assess his rate of breathing, that's going to tell me something else. Okay? This is what I mean. Let me know if somebody comes to the door, because who are we missing?
We got
Aaliyah. Yes. Hey. Glad you could join us. Please sign in before you leave. We need another chair. Here, take this chair, slide it down, and then I'll grab this one. They're going to put you in the corner, girl.
I can deal. Make a little bridge.
You can switch if you want.
Oh, it's okay, baby. Thank you.
Okay, so
I appreciate it very much.
when we start into patient assessments, this is going to kind of come together for you. We fix what we find in the ABCs, and we do it pretty much immediately, okay? Because again, higher priority is to ensure they're not hypoxic. We want to make sure that they have adequate oxygenation. And then, you know, blood glucose would be another one that would kind of call it altered mental status and some other things. We have an entire list of what causes altered mental status, but those are the top 2 that we're very concerned about that we can reverse and fix immediately.
Low glucose.
Okay, so when I'm assessing my patient and I'm assessing breathing, I already know their airways patent and open and clear is the fact that they're talking to me. Pay attention to how they talk to you. Are they talking in full sentences? Or are they talking 1 or 2 words at a time before they're having to take a couple of breaths before they can finish that statement? You know if they're only talking 1 or 2 words at a time, they're in distress. Is that how you normally talk? So what am I telling you? I'm in distress of some flavor. Okay? This is how you're putting pieces to the puzzle together. Pay attention. This is where you have to be like detail oriented. When we talk about breathing, we talk about rate. We need to know the rate of how many times they're breathing per minute. Is it adequate? Is it not? Okay, we have a nice range that we like to think about. Again, a range that we should be very familiar with right now. 12 to 20 breaths per minute is what we're looking for as far as a range. Anything outside those ranges, we need to determine and assess, well, is this patient just a runner and that's how come his respiratory rate's 10? Or is this because of other issues and I really need to be aggressive with how I treat him? The questions you ask are going to be very important. How you ask those questions is even of more importance. If someone's in respiratory distress, am I going to ask them closed or open-ended questions? Closed. Why?
So they don't have to speak a lot.
If they're already in distress, why would I want to compound their problem by asking an open-ended question? Because again, understand the difference between the two questions. A closed-ended question is that you're getting precise information by asking a question that they can shake their head yes to or no to, or let me have your hand, if you don't mind. If, ma'am, if it's yes, just squeeze my hand so I know. I don't want to further exert her by asking her an open-ended question. An open-ended question is, well, tell me your life story. Okay, I don't have time for that. When I see someone who's tripoding, who's breathing 38 times a minute, very shallow, I need specific questions asked. This is all part of history taking when we start talking about patient assessments. Okay, so again, this is going to be important. Now, if we have, let's go back to our scenario, okay, we have a person who's called because they've had a cough and cold, maybe a fever for a couple of days, they called you out there. Okay, so as you approach the patient, you see that she's very calm, she's not in any type of distress that you can see, so you have made the general impression of your patient that I looked at her as a whole, she doesn't look like she's in real distress right now, but we're going to say she's not sick right now. That's your general impression. Then as you're talking to her and you're asking questions, then pay attention of how she responds. Because if she's very short with you, then you need to say, okay, ma'am, well, I'm just going to, then in your mind, you're going to change the questions from open-ended to closed questions so that now you can do a breathing assessment and find out what a rate is. If her rate is outside the parameters, then we need to give her some supplemental oxygen. Now, you can always start low and go high. There are certain circumstances where immediate high oxygenation is going to be given. But in a situation, the example that I'm giving, okay, her rate's like 26 times a minute. She's a little labored. Now I'm going to assess and I'm going to listen to her breathing. Well, she's got a little bit of congestion down there, and then she coughs in your face, and then you hear the gunk. Okay, so now we know that she's got some type of infection because you can hear like the mucus roaming around, and when she coughs, it's not like a, it's more like a type of cough. Hear the difference? So, in order to assess her, now I'm going to put my pulse ox on here, and I'm going to put it on her finger. Hey, can I borrow your finger, ma'am? I'm just going to put this on there. No, I'm just kidding. Okay, so now, after assessing her, listening to her breath sounds, listening to the way she's talking, I found a rate, quality, and character. Her rhythm is regular. It's got adequate tidal volume because she's able to talk to me in full sentence. And then now I have a diagnostic tool that can help me determine, should I give her oxygen or should I not? It's greater than 94%, is it not? So do I want to supplement her with oxygen right now? You see how it's fluctuating a little bit? Now, here's the thing. I gave you this particular scenario for a reason. You have to understand that oxygen is a drug and it has side effects. Actually, some positive side effects on our behalf. One of those is the fact that it has a cooling property. So, in the fact that when I touch her and I feel her skin and she's hot as Hades right now because she's running fever, I'm going to give her some supplemental oxygen at a low dose in order to help with the cooling effect in order to try to bring her temperature down from the inside out. So when people run fevers, yeah, she's got a great pulse ox at 98%, that's great, but just a little bit of tidbit of information is that oxygen has a cooling effect, so we can kind of supplement her. Now, I'm not going to give her 4, I'm not going to give her 6, I'm going to start her off maybe 1 or 2 in order to help with the cooling of her body, since her body is so hot, and it's normally hot because she's running fever. And as I talk to her, and as I find out whether or not she's got a medical history, what type of medical history questions do I want to know about her? Let's say she's middle-aged.
Mm-hmm.
What type of questions do I want to know if I need to supplement her with oxygen? Does she have any respiratory issues? Remember what oxygenation is for. Respiratory issues. Another thing, does she have any cardiovascular issues? Because again, one system works hand in hand with the other system. So those are the 2 priorities. If she's calling me and she's having trouble catching her breath, quote, quote, okay, these are 2 top questions that I need to know. Ma'am, do you have any type of respiratory problems? Like, do you have a history of asthma? Have you ever had a cold where you got pneumonia? Or do you have chronic allergies that causes you to have, distress or whatever? So these are some of the questions I need to ask. If she's got a respiratory issue, then okay, beep, red flag should be going off of, okay, I really need to pay attention closely to her respiratory system because she's got a history of it, and oxygenation is going to be a priority. Does this kind of make sense? Does this kind of help put things together for you? I'm here to tell you that the majority of the services out there do not carry simple face masks anymore. It's just one of those things as an EMT you have to know. Okay. We normally carry nasal cannulas, partial rebreathers, BVMs, and nebulizers. That's about all we carry now. They took, I think, simple face masks off of 5 or 6 years ago. But still one of those things that you might want to keep handy, because there are services that's in the rural counties that actually still carry those. They never took them off, which is fine. It's all dependent on the medical director of that service, but there are certain rural counties that have those still. But as far as here in the, urban areas, we don't carry those. We took those off years ago at Grady. Because again, it was either we want to give them some to kind of supplement, we either give them a nebulized treatment that has medication in it, or we're just getting them full-blown 100% oxygenation, if you will, okay? In order to determine how much oxygen you should give, take the picture, the entire picture of your patient. Pay close attention to respiratory rate. Pay close attention if the scenario you're reading says anything about lung sounds. If it's not normal, that should be a red flag. Okay, oxygenation needs to be given somehow, but okay, let's see what the respiratory rate and correspond the 2. That's the range that we want them to be in. Anything on the other extremes or above those or below those, oxygenation needs to be given. That's what chapter 10 was the importance of 1, oxygenation, and 2, recognizing if my patient needs assistance with the mechanics of ventilation. I told y'all, if someone's breathing very shallow, are they moving a lot of air? No, it's not adequate. So that means we, who've got a bag valve mask, is going to provide positive pressure ventilation to them in order to have that. Whenever we do the breathing for them, we're going to do it once every 5 to 6 seconds, and then that's going to be drilled into your head whenever we take BLS. Rescue breathing for someone with shallow respirations or no respirations at all or very, very slow, okay, it's going to be 1 every 5 to 6 seconds. And if they're breathing like this, on that one breath that we happen to catch them at, and we're squeezing that bag, we're going to cause this to go for that 1 second, and then they're gonna go back to this in 1 second, okay? I'm increasing tidal volume. I am assisting them with the mechanical aspect of ventilation. So it's important that you pay attention to the presentation of your patient. Rate will always come first when it comes to breathing. Rate, rate, rate. Because if you immediately go to listen to breath sounds and you're not paying attention, because guess what? When you've got the stethoscope here, they're going to have to do a full respiration in order for you to be able to hear both inspiratory and expiratory. And if you're not paying attention to the rate, well, you're going to be going, dang, I don't hear anything. And then recognize later on that they're only breathing 4 times a minute, then you are way behind the 8 ball. Rate is always going to come and be important. Rate, I'm going to tell you all that until I'm blue in the face. Rate will always come important, just like with circulation. I don't care about their skin and stuff like that. If she's got a pulse rate of 150, I'm concerned. I need to know that ahead of time. Not after okay, well, yeah, she's gonna, okay, now, ma'am. And then you totally forget, or you're looking at this pulse ox right here, because again, pulse ox does beats per minute as well as a percentage. Do not be dependent on this thing to correlate with what is going on with her circulation unless I've got them, can I borrow your hand? Unless I'm doing both at one time. I'm counting here and I'm looking at this to ensure that they're the same. That's the only way I'm going to know that this is accurate, is if I manually check her pulse and the rate. Does that make sense?
Yeah.
Kind of putting things together a little bit for you. Now, there's certain circumstances in which high flow oxygen is going to start off at the very beginning. Unconscious, unresponsive patients. Okay. We don't know how they got there, but we want to ensure that it's not due to hypoxia. Something easily that we can help reverse if necessary, or an unconscious, unresponsive patient that has a low rate of breathing. We're going to assist to bring them up to a range that we're comfortable seeing. Plus, we're providing with them 100% concentration so that the cells can stay in aerobic metabolism. Okay, I can't stress that enough. We're trying to save as many of those little bitty cells, because the cells is the functional unit of an organism. Because again, if you understand the hierarchy, if we don't save the cells, then that means tissues are going to begin to die, organs are going to die, and then the whole organism will come next. So you have to understand the hierarchy. If we can save these little cells, that's great, because that means less tissue damage will occur, which means less organ damage will occur, in which I can probably save my patient at that point.
Can't treat the organ damage.
Okay. Oxygenation, ventilation is important because you have to have the oxygenation by the mechanical means, because if you don't, you're not going to have what you need to survive. So, a couple of students had asked me why we were kind of going out of order as far as the book is concerned. And partly the reason is that, one, we needed anatomy and physiology so you can have a baseline of all the body systems before we went into oxygenation, ventilation, and so forth, because after that, then we're doing BLS, which is nothing more than CPR. You have to have a general foundation of the systems in order to know how they interlink with one another, so that oxygenation is very important, and chest compression is going to be the last part, but you have to have a foundation. EMS, work safety, proper lifting, all that stuff, the first 9 chapters is what the majority of EMT students are failing on National Registry. That's how come I kind of go out of order, because I want that to be closer to the end of the semester, because next semester it's all about special populations, trauma, and then bam, you're in clinicals. So that's how come I take those and kind of establish it over the 16 weeks in order to kind of keep that toward the end of the semester, so it'll kind of be fresh. And then once we start, we're still going to be pulling from that information throughout next semester so that it kind of stays fresh in your mind, especially prior to going and taking your certification test. Okay? There's a method to the madness, I promise. Okay? Oxygenation is very, very important. I can't stress that enough. Number two is that you have to understand your equipment and when the time to give it. If you are assessing the first 5 and you come to breathing and things just start normal, you find something out of the ordinary, this doesn't match my patient presentation, give them some supplemental oxygen then, not later on in the game, because this is one of the very major differences that I teach you in this class. Is whenever we talk about monitoring devices and stuff like that, I think in chapter 11, and they talk about baseline vitals, you have your baseline vitals, if you will just work with me, within your first 5. I've already established airway. You're talking to me. I've established breathing because I'm going to count. Okay. I'm counting the rate. I'm listening to my patient. I'm looking for adequate chest rise and chest fall for adequate volume. If I determine she needs some supplemental oxygen then I will put her on it. Because again, I don't know where she is and how long she's been struggling, but I'm going to try to correct the anaerobic back to aerobic. Because again, the waste products of anaerobic metabolism is deadly. I can fix that pretty quickly with just A and B of the first 5. By the time I get to circulation, that all has to do with, okay, pulse rate, blood pressure. Okay, here's the thing. They only tell you pulse rate, skin color temp, and maybe your CRT where you blanch the fingertip. They don't tell you about the blood pressure. I teach you to incorporate the blood pressure with circulation because now you have baseline vitals of your patient. Let me stress this to you. Book knowledge. Baseline vitals is a secondary assessment. Book knowledge. Baseline vitals is a secondary assessment. I am teaching you to get baseline vitals within the first 5 because now you have a good indication of whether your general impression of your patient is the same or has it quickly changed because of some of the assessment findings in the first 5. So if you should ever see a full set of vital signs on a test, that means you have addressed the first 5 and you are now in a secondary assessment. It's very important to get baseline vitals at the patient's side where they're at prior to moving your patient. Because if I tell Aaliyah, I saw that right palate. If I tell her, hey, why don't you just come on up here and walk to my ambulance and I'll put you in there on the stretcher, I don't have baseline vitals. Her body is now compensating from the shift from sitting to standing and walking and then going back and sitting down. I don't have an accurate set of baseline vital signs on her. I want to take that when she's sitting down, when I find her, when I'm talking to her, and then now I have a baseline set of vital signs so that if something should change, I'm going to know about it. Because again, we take vital signs periodically because we want to know, is she maintaining? Is something else going on I don't know about? So it's a matter of the continuity of care. You're trying to show a pattern. Well, she was pretty stable when I got to her. These were her first set of vital signs. 5 minutes later, I took them again. They're relatively the same or a matter of points among each other. And then the third one, I don't know what the heck happened. She just bottomed out. We're trying to show a pattern of compensatory mechanisms that my patient is going through.
So the first assessment is general impression for book knowledge.
That's part of the first 5. That's a primary assessment. So the first 5 is considered your primary assessment. Okay? That's considered primary assessment. Now, scene safety, again, I can't stress enough. Your safety comes first above all else. There is one thing that I told you I could not teach you in the field, is that gut instinct that kind of tells you something's not right. You get the hair standing on the back of your head, your heart rate increases and you begin to sweat, and your gut is telling you something. Please listen to it. Please listen to it. I don't know how many countless times I have seen medics go into a situation and they told me after the fact, you know, hindsight's always 20/20. Yeah, someone just told me not to go in there, but I did anyway. If something in your gut is telling you something is wrong, I don't care if you're standing right in front of the door and you're about to knock on the door, or I'm sorry, standing to the side of the door before you knock on the door, and something is telling you something is not right, you get an eerie feeling, please turn your happy butt around, get back in your ambulance and move down the road and call for police. Because once you're in that situation, you may not come out alive. I'm just being straightforward with you, okay? If your gut is telling you something's not right, please listen. Scene safety. Your safety comes first above all else. When I was teaching the military, Combat Lifesaver, that was one of the hardest things that soldiers had to wrap their head around while they're trying to save somebody, because, oh my God, that's my battle bud, you know, we gotta go get them. And that was their first instinct was, whoo, and then they get shot too. And so now they're laying down beside their battle buddy. Okay, so again, that's one of the concepts that military folks had an issue with. I totally got that.
Our scene safety is fire superiority.
Exactly, exactly. Totally different mindset, because again, y'all are prepping for war, whereas we are not. Just war in a different way, it just kind of depends. Okay, but again, you have to look at it that way. I cannot help somebody else if I'm laying next to my patient. Okay, you've just defeated the purpose of your entire job, which is to help somebody else. So always ensure your scene safety. Now, when we talk about scene safety, as you're entering a room, okay, and here's the whole thing about National Registry, and I teach you this early, and we practice early, because I need for you to get into the habit of voicing everything that you're doing. So if I give you a scenario, and you've got your jump bag, and you and your partner come into that door, you better say, is the scene safe before you knock on that door, because if not, I'm going to blow you away through the door. Or I'm going to have a sniper or a family friend come up and shoot you and you're dead. Okay? I've done that. You should see the expressions on the students' faces. Always clear your scene. That means, okay, come on, sit down, come on. Okay, sit just like that. We're driving to the scene, okay? We're almost there, right there. I can see the house right there. Is my scene safe? Any dangers I need to be aware about? See anything? Okay. You're having to voice everything, as silly as it sounds, okay? As silly as this sounds. You need to clear your scene. I'm driving up to the road, okay? Do I see any scene? Any danger? Do you see anything in there? Okay, all right. Open the door, get out, grab your stuff. As we're approaching the door, okay, here's one of the things that you need to be very aware of. Do not ever, ever, never stand in front of a door to knock on it. You will always stand to the side of the door, and that's how you will knock. And you will loudly say, hey, EMS, we're here, it's just us, whatever. Did you call 911? EMS, EMTs are here. Always to the side of the door. Always to the side of a door. Now, here's the thing. For those of you that can't multitask, here we go. Ready? Not trying to point anybody out.
Go lock the door.
Notice I'm standing to the side of the door, right? Okay, just checking. I have all my equipment with me too, okay, including the stretcher, so visualize this with me, okay?
All right.
Y'all with me?
Yeah.
Okay,
Yeah.
just checking.
We're good.
We didn't order any.
Avon!
Not the
Okay,
beef
so
one.
now-
Do you have time to talk
I
about
know,
Lord
right?
and Savior Jesus?
Now, here's the kicker, multitaskers. I'm in an unsafe environment. I don't know anything about this room. I don't know anything about the patient I'm dealing with. I don't know who may be hiding in those closets, behind that module, in that module. So guess what? Here's where you need to multitask. You need to find and remember where every exit, every possible exit there is in this house. You need to know the possibility of someone hiding in the closet, hiding behind a door, down a hallway, in other rooms that doors may be closed off. This is the mental picture you're having to play. Because again, the uncertainty and the unpredictability of the place you're going into, I'm asking you to put your life on the line every day when you go into someone's house. You need to know where your exits are, all of them, including a window. If you can bust through it, run through it, whatever you think you need to do.
Guessing if possible, just position yourself near one of those exits during your assessment, if possible.
If possible, that may not be always the case.
Yeah, there
You may be in the center of a living room and you have all these hallways coming from any direction that's got doorways. You don't know who's back there.
Would that be one of the things we asked as well? Are you alone in the house? Or
You can, it wouldn't hurt.
yeah.
Just, again, patient presentation is gonna dictate whether or not you ask that question.
Fair enough.
Okay. One of the other things that I teach you is that you go in as a crew and you leave as a crew. You're never separated, except for this exception right here that I'm about to tell you. If at any moment a person were to come out down a hallway with a gun or threaten your life or something like that, then if your partner or yourself has a way to get out, then you need to get out and leave your partner there. As horrible as that sounds. Because now your partner who just escaped has a layout of that entire house and can tell the police and the SWAT team when they get there how things are laid out in order for them to know how to approach and get you out safely. That's the only kind of exception to the rule. There's another exception, and that's when you have a mass casualty incident, which kind of changes the whole scenario. You have to be mindful of this when you are approaching someone's house, when you actually get into their house, because again, the unpredictability of the scene that you're in. The only safe place I know I can count on is the back of that ambulance. That is my workspace. I know where everything is on that truck. I know what can be used against me as a weapon. I know what I could do to use against the poor guy laying on the stretcher, okay? I know what's in the back of that unit. I can also lock the doors. I can also have my partner get in the front seat and then drive us to a safer location if need be. But I'm asking you to put your lives on the line every day, not only going into people's houses and the unpredictability there or in a restaurant or wherever you're going, but I'm also asking the person in the back of that ambulance to put their life on the line, because should that ambulance get hit, guess what? You're not restrained. Especially if you're doing patient care. Now, do you want me to pull up all the ambulance wrecks that have happened within the last month? There have been 45 across the nation. 45, and it's going on a rampage right now. I'm not sure why that's kind of increased within the past 5 to 10 years. Ambulance wrecks are now occurring almost on a daily basis. So I'm sorry I can't give you that nice cush 9-to-5 job where, you can have breaks and things like that. You're always on the go, you're having to eat in between calls sometimes. You may not even get a pee break until after you get to the hospital. And this is what I'm asking you to do. So it's important that you multitask when you get into someone's house or an environment you're unfamiliar with, which is just about every other call. And you need to take a mental note of the layout of the house and what your entrances and what your exits are, all of them. Because again, it's unpredictable. And if something's telling you once you got in that house that something just isn't right, then you hurriedly put your patient on your stretcher and you get the heck out of Dodge and you put them in a safe environment that you're very familiar with. If not, then you need to call police out there. Again, That's one of the things I can't teach you is how to listen to your gut. Okay? Now, everybody come on, get up. I'm gonna show you some stuff. Y'all are already familiar with the pulse ox. Okay, when we start talking about monitoring devices. Now, here's another thing that you need to understand about multitasking whenever you and your partner are dealing with a patient. If I'm assessing her and I'm assessing her breathing and I want to know what her pulse ox reading is, after I find her rate, then I will apply the pulse ox to her at that point. Because now I know the rate, I want to know an oxygenation level, and then I can actually listen to her. I'm actually going to auscultate and listen with her to her lung sounds. So again, it's important that you start bringing your equipment if you've got it. So if you've got stethoscopes at home, bring them. Okay, because we're going to be putting our hands on each other. This ain't the time to be shy. We're going to be all over each other. Okay, we're going to be very close. You're going to be listening to each other. You're going to take the time to listen to each other. Because again, I'm training your ears to listen to what's normal. For those of you that's got grandparents or something like that, or someone that's got asthma, a friend or something like that, listen to them, okay? Once you understand what normal sounds like, then you're going to understand what not normal sounds like. And then all of these different sounds that we listed on the board, like wheezing, rales, rhonchi, things like that, is all going to come into play. But I've got to train your ears now on what normal sounds like. It should be nice and clear. You should hear air going in and out. Okay? If there's an obstruction, you're going to know it because it's not going to sound, it's going to sound very different. Monitoring devices. This is a monitoring device. Again, a diagnostic tool to help us make a determination, but this is not what I'm treating. I'm treating my patient. If her presentation is contradicting what this thing says, then I need to pay attention to her and fix her. I'm here to tell you, there's the majority of the people out there in the world, especially on the ambulances, who's been doing this for quite some time, will treat that monitor versus treating the patient that's now blue in the face and stuff like that. Oh, their pulse ox reading's like 98%. What's the big deal? Monitoring device. Another monitoring device that we have is an AED, which you'll learn on Thursday, next Thursday, whenever we talk about basic life support. Okay. Another thing that I have in there that's a monitoring device is my LifePak 12. Okay. All right. Monitoring devices. Okay. I don't think your book goes into the glucometer yet, but again, monitoring devices. Okay, blood pressure cuffs. Okay, that's a form of a monitoring device in which I have to manually put this on a patient in order to obtain their blood pressure. Now, there's rules to everything. Blood pressure cuff. How many of y'all ever gone to the doctor and you just felt like they put like an oversized cuff on you? That happens like all the time, or maybe one that's too small. Okay, there's rules to everything. Blood pressure cuff is one of them. And this is why you have to understand your equipment and how it works. There is a bladder in this thing that goes from the outside. You can actually feel it. If you don't believe me, grab the other one and feel. There's a bladder that starts here and ends here. When you actually put this on a patient, come here, Michaela, because you're kind of small and I think you do, okay? When I'm monitoring her blood pressure, right, I have to understand how my equipment works. The bladder is to fit on her upper arm 2/3 of the way around. If anything is more than that or less than that, I've got the wrong cuff size. Upper arm, always the upper arm, almost mid-shaft, when we apply a blood pressure cuff to someone. Now watch very carefully, okay? I don't want to put this thing on and it falls right off. That's not going to give me an accurate blood pressure, okay? When you put a blood pressure cuff on someone, it's got to be snug, okay? Okay, I'm going to rotate the one this way. Look, y'all. thing even got visuals for you. Look, it's got an arrow that says artery. Remember the arteries that we were talking about in the arm? Okay, the brachial artery comes straight down here. Actually, it turns into your antecubital before it branches off into the ulna and radius. Okay, so guess what? This little artery arrow is going to go on that artery. Okay, again, halfway upper arm, ensure that the bladder is about 2/3 cover, and then I'm going to make it snug to where it's not loose and it can't just easily slide off her arm. And then this is where, you know, I'm going to pump up and then I'm going to listen, which we'll go over here shortly, okay? But this is proper placement of a blood pressure cuff. Make sure you understand the rules to the blood pressure cuff. Because I'm here to tell you, we may carry 3 sizes. A normal, what we call normal adult size, and a large adult size. I'm going to pull out one of the other ones I have, and it's actually a full kit where it's infant, child, normal, extra large, and then a thigh one that we can actually put on a thigh and actually take some of the blood pressure on the thigh. But for the most part, we carry a normal adult size and a large adult size.
The bladder, it's 2/3.
2/3. Okay. Monitoring device. Okay. We didn't scare you off?
No, I'm just gonna write it down.
Okay. So something else that you need to take into consideration, and again, part of the reason why this bag is bigger is because it came with its own stethoscope. Okay. I'm gonna teach y'all how to do this properly. This is not right. Okay.
No, she's so much better than that.
I'm just anal about things. Okay? One of the other things that you need to pay attention to, right, is the dial. The dial's got to be at 0 in order for you to work, for this thing to work and give you an accurate blood pressure. When I send you to clinicals, every set of vital signs you are to take is with a manual blood pressure cuff. This is the most accurate in the field, not a machine. Which everybody's got 1, 12, and 9 notes, and then they just hook them up to the blood pressure cuff, and then they just, no. All the vital signs you will be taking is going to be with a manual blood pressure cuff.
Sometimes you're not going to be able to bring your truck to the patient.
That, and the fact that those are not calibrated every day, and they can be anywhere from 5 to 20 millimeters of mercury off on both sides. Should be.
Yeah.
You should run your little testing things on there, and some people don't. And plus, if you think about how bad those things get thrown around, knocked around, carried around, kicked around, it's the same thing in a hospital setting. What's the first thing that they do?
Yeah.
Ding. Okay, and how old are you? What are you here for?
Yeah.
Okay. I don't trust those either. Because here's my thing. I know my blood pressure. And whenever I go in there and say, wow, your blood pressure's high. No, it ain't. And no, you're not about to put me on high blood medicine. That's the only thing that the doctor's going on to determine whether or not they're going to put you on blood pressure medicine. So if you know your blood pressure and the range that it's supposed to be at or what you're normally seeing, and it comes off the wall, I strongly suggest that you look at the nurse and go, hey, can you take a manual blood pressure? And I guarantee you they're going to go,
You're an EMT, aren't you?
what? Okay. They're going to be looking at you funny. So again, make sure that you understand why you do the things you do, okay? Now, I'm sorry, but I'm just anal when it comes to these things, as far as packing them back up, okay? I'm sorry, I just am. I don't like those ones, okay? Sorry. So basically what I do is I just kind of gather it like this, okay? And then twist it up like this, and then you just kind of roll it into place so that whenever you're ready to bring it out, it's out, and you ain't got to do this number, and you don't hear this part of putting it on the patient. So again, it's just, I'm just anal about stuff. So basically you can do it like this, or you can roll it to where you're not hearing the Velcro, and the only Velcro should be when you put it on a patient, okay? So another monitoring device. One of the other things that's within the vital signs, if you will, is pupillary response. So if y'all don't have one, you might want to invest in one. These are great. They're a little bit sturdier than the disposable ones, and plus if you run out of the battery goes out, you can always replace it. These are reusable, whereas the other ones are not. Pupillary response is very important because I told y'all the pupils are the windows to the brain. Remember all of the vital sign centers that's in your midbrain. Okay, for things to happen, things to occur, for pupillaries to respond, it's got to have enough oxygen and glucose in the brain for it to work appropriately. So with this one, these are, okay, so we're looking for pupillary response. On a bright day on the outside, you're not going to be able to do pupillary response. You're going to have to be very ingenuitive on how you do pupillary response in broad daylight sunlight. Okay, so that means either cover their face, cover their eyes, and then you quickly and do the other side, because basically what should happen is that when you approach the eye with the light and you're starting from the outside and going in order to get the pupillary response, you want to know, one, does it constrict like it should? And then when you retrieve the light out of that area, does it kind of somewhat dilate a little bit like it should? This is what you're looking for. This means that if I do it to the right side, the left side should do the same, because your eyes work in conjunction one with another. So if you actually do this right and look at it right, you can do both pupils and see that they're going down and opening back up. Now the pupil that we're talking about is the actual, okay, so here's your eyeball, and that little blackness that's in the very center of your eye, that's what we're talking about. We're not talking about the whites of your eye, we're talking about the very center pupil portion of your eyeball. Okay, that's what we're talking about, pupillary response. Another kind of monitoring device, especially if you have someone who sustained major head trauma, anything like that, you want to check their pupillary response often. Okay, for the reason that if something changes, their pupils are going to be the first things to change, which means that they're not going to be responsive to light. They may be blown, in which there is, you know, it kind of openly and dilates, has no pupillary response and things. So another kind of monitoring device. These things we kind of have already set into your bag, which is great because, again, I kind of like the way you have things laid out, and the fact that every patient, you're going to come from this department. Then you have your oxygen tank that's got all your O2 equipment or O2 delivery devices. So this is great. Okay, why would I want to open here, come here, grab here? Okay, because the less I can open and stuff like that, you're saving time when you're dealing with a patient. Does this kind of make sense? Okay. All right. Anybody have any questions so far? Okay. So what I want you to do is I want everybody to go grab one of those little horrible stethoscopes that's on the back wall. Grab an alcohol prep, which is right here.
I told you.
Clean the earpieces, and then I want you to start listening to people.
These look small, like they're gonna go in my skull. There's a big one right there.
Look at this shit.
Right here? Yeah.
Oh my goodness.
Oh, some of these are dirty.
You got a
I
lemon
thought
too?
about it too. I was running
this
late.
is
I was
a-
like,
No,
let me
this is
grab
so
this.
sad.
Mine was supposed to be here, but Amazon was messing with me.
Oh, that is so nice.
Mom, you can share.
All right.
Man, I'm so sad I'm not going here now. I'm so
You
excited.
got the rainbow crunchies?
Yeah, it's so
Yeah,
cool.
I didn't want that.
Oh, you getting fancy?
Whatever.
Bring out the fancy one.
She had to
Showing
coordinate.
off over here, alright.
But
Let me see
Aaliyah and
this.
I are prepared.
Okay. Apologies,
I
you
ordered
guys
the
are.
same
Oh, look
one.
at these.
You
These
did?
are real
Yeah.
nice.
I think
Okay,
I got the
so-
matte black one and so
Okay, so when we are listening to breath sounds, okay, this is the thing. You know how whenever you get to the doctor and they want you, they put their stethoscope, take a deep breath in and out, take a deep breath in and out, take a deep breath, and then by the time he's done, you feel that lightheadedness and your nose is tingling. Okay, we don't want your person that you're listening to pass out. Okay, So this is what I want you to do. This is how we're going to train your ears to listen to what you should be listening for. Something that's normal. Nice, clear sounds in and out of the airways. So when you listen, mid-clavicular line is very important. So we're going to listen up on the chest, mid-clavicular. Now, in order for you to hear inspiration and exhalation, guess what? You're going to have to wait for the cycle. So don't tell him, okay, inhale, inhale, exhale, because there's 14 different anywhere from 12 to 14 different locations we have to listen to. So this is the time where you take your time to just allow the patient or allow your partner to breathe normally and listen to the sounds when he breathes. Don't tell him to over-exaggerate. Just have breathe normal, and then I'm just going to listen, and that's what I want you to do. There's 12 locations. Are you watching? 1. Remember, we need to know if it's bilateral, so it'd be 1, 2, mid-axillary, right, 3, 4. You can even come down a bit here if you want to on the chest, okay? And then whenever we get to the back side, because we've listened to mid-axillary up high and down low, then we're going to listen to the back side, and we're going to start at the top to where you can hear the apexes, okay? And you're going to start here, you're going to listen, then you're going to come on the opposite side in the same location, and then you're going to slowly come down until you hit the bases, okay? This is how we listen for breath sounds, okay? Sorry. Okay, so this is what I want you to do. Take your time and listen to your patient, because you're going to go from different people. Okay? Everybody okay with that? All right, cool.
Here's what.
Yes, you do.
Now, pull yours out. I want you to understand that these are movable, okay? The reason why he can't hear anything is because he has these things straight into his ear. He does not have them pointed and angled into his canal. So kind of shift it, manipulate it, and then ensure that you're listening to the right bell. Because if you were to twist and it doesn't lock, you're not going to hear anything. It's got to click. So you'll either have the pediatric side or you'll have the adult side. Okay? So tilt it inwards where it's actually pointing in your canal. Okay? Now, thump on which side? Okay. Now again, if you have a hard time hearing, close your eyes and focus on your ears. Close your eyes, because once you close off a sense, another sense will enhance. Take your time to listen and close your eyes very carefully. Listen to the sounds. You're trying to listen to the air in the airways. Okay? Go. Just kidding.
I can't get it.
Go with your fancy.
I'll be right back. Use your restroom.
We're
Sorry.
gonna have an evening, so.
Make sure.
I can hear my heartbeat.
Listen to
You don't want
heartbeats
those
too.
pointed, like, forward, so you actually don't towards your ear, so just turn it on.
These are mine, so.
You don't really hear much on the
Yeah,
other
just, like,
side,
you're
though.
facing it
What?
like
Even on yourself, on the other side, where your heart isn't at.
It's so faint.
Yeah, you don't really hear shit.
No.
maybe one side.
So it's like, can you hear? Can't really hear that.
Do I have this on right?
Yeah. Yeah, that way. Supposed to be that way.
That sounds better. I can barely hear you.
Really?
Yeah.
Let me see.
I just hear your clothes running against it
Yeah.
when I move.
I guess you probably have like the patient sitting to do that.
Probably.
Try that again. You guys move?
I hear it.
You hear it?
Yeah. Okay, so
Am I tripping?
do it like
You
this.
put it under your shirt.
I have.
Alright.
I mean, that's a good idea.
Yeah. I mean, they do it at the doctor's office.
Alright.
I don't like that.
yeah, I don't like that.
No.
No?
There we go.
I just have
Say
to
I'm
hold
not
my
dead.
breath so I can actually hear it.
What?
I say I'm not dead.
It's just like,
Yeah, try
Keep
to
in mind, these are
Oh,
also
you need to
like,
breathe
just
too.
feel man.
these are also real bad.
Yes, we barely hear it once you really concentrate.
I think my earphone just got one.
Where's your Littman at?
Upstairs in my office.
No.
Safe space.
I'm gonna bring a couple of them that I have at home.
Need to
One's
practice.
my Littman, and then the other one's like an off-brand, but it's a cardiology one that's got two bells,
Mhm.
you know, that you can swap.
Yeah.
So I'll bring it to, so that y'all can listen. But again, you kinda need to kinda train yourself on how to listen.
I can use yours.
I'll just stand up since you're super tall.
I can hear yours good on both sides.
Wop, bop, a loo, bop, loo, bop, bop.
Yeah, good. I mean,
We're all just going on.
Like,
You can
while
have
you
the
sit
three.
down.
You do it.
can't really hear it on this side.
You really can't.
Yeah.
I'm really getting what you're talking about. These
Yeah.
are really.
Cheap. Yeah.
Yeah.
You want me? I can breathe louder.
Yeah, if you wanna do the,
Miss Bush, can you come here? Make sure I'm not tripping.
Yep. Make sure.
I can't really hear like on the mid-axillary line and the
Yeah.
and the posterior.
You don't mind if I
No.
use these? Okay. So whenever you're listening, right? Okay, so again, just breathe normal.
Okay.
Okay, just breathe normal. Yeah, that's pretty loud.
Really?
Yeah. If you need to shift, shift. But again, because of the outside sound, you're having to just close your eyes and focus. And then if you still can't hear her, then have her take a deep breath where she'll make it obvious for you. But again, you have to train. You don't know what you're listening for yet, so that's how come it's hard to hear it.
Okay.
Yeah.
Close
And,
your
and
eyes.
that's okay because like I said, practice.
Yeah.
So if you meet and you have a study group that's in person, then that'd be the time to practice too.
We can all do it on Sunday.
Yeah, yeah. You all got this? But like I said, if you
I
still.
can hear it now.
Here,
The sweet spot.
Yes.
right? So here, then here, then here,
You hear it? Okay, let me
Yeah.
try it.
there.
It's like a certain
We'll
spot.
do, but the exact location, I mean, we're gonna be kind of fiddling around at first till we get used to exactly where that is.
Oh, okay.
The sweet spot.
Cool.
Do you hear it? Not really.
And we'll go again.
Yeah.
I took a deep breath.
Yeah.
Sorry if you don't mind, I need a snack. I have a meeting this morning.
I had McDonald's this morning, so it's okay.
Did you?
I'm about to go hit up Clearview and get one of those sandwiches, get some potato salad put on it.
Tape
sauce.
salad.
Oh yeah, have you ever had them? Oh, what? You got what's on?
You like that one?
Oh, she calls it a sesame too. I mean, don't worry, everybody was a sesame at the same time. Like they all came around and they're just like,
Oh, you know what?
So yeah, she's not lying. Invest in a good pair of these, and we'll definitely have them to practice. Maybe the
Yeah, like I said, you really need a good stethoscope.
It's about to be.
Yeah.
Real good, right?
But the only part I put in is the top part.
You can, but it's like, I used to have it, but it's like.
Oh,
You can hear it, but it's
Pretty
like,
just yeah.
right down here.
Just trying to close.
Why are you?
So you can hear it
Maybe
better.
I need to do a different one.
You do want to like
I
beat
was.
forward.
Yeah, I'm looking forward a little bit. I didn't want to be like, oh. I look ridiculous.
Now you're talking my language, man. We want brisket.
I'm going to the Clearview barbecue if they're open today. It's literally just right around the yeah. Yeah, they're like it's like it used to be $1 a sandwich. I don't know if it still is. It's been a while since I've been there.
It should be.
I think
I-
it might would change it.
Last time I was there was like 2016. So
But
it's
it's really good. Well, like from I worked at Pinterest for a while. Like, you know, you can find like
Like a $30, $40 one of these, I'm definitely gonna invest.
I like the run. That's about all I like. About
Just
it.
run it lasts longer, I guess.
Yeah.
Yeah,
There's a place down here that does like a good smoked brisket or smoked.
Country's does a really good brisket.
Yeah,
I will say
Country,
that.
yeah,
Country's
Country.
is a really
I
good
gotta get
brisket.
in.
It's not that far.
Someone with a
There's a bunch of
stethoscope,
them.
come here.
Actually,
Say again?
what's that?
Someone with a stethoscope,
A
come here.
working one?
It's yours.
A good one?
Let me see if you can hear how many graves.
No, no.
I heard something. Yeah, I can hear it.
Come on. Really? Okay, so next week we're gonna play with Bob.
Hey Bob, how you doing?
Whatever reason my ThinkPad's not coming on.
Is it charged?
Oh, that's the machine itself. Okay.
Okay, so next week we're gonna play with Bob. And after you've had time this weekend to listen to each other and stuff like that during your study session on Sunday, then we're gonna break Bob, and then I'm gonna actually put sounds in that you should be able to recognize, such as wheezing, rails, things like that, or at least be able to listen to him with those particular sounds. Now, again, with Bob, it's not gonna be the same as if you're doing on a live patient, because again, you've got to hit the right spots with your stethoscope in order to hear the sounds, and on him, they've got like a little, like a sound, what do you call those?
Indicator.
Symbol, indicator, okay, and that's where you need to put your stethoscope to actually hear the sounds. But,
You can hear it basically.
Pretty-
all over
pretty
this.
good?
Yeah,
Okay.
yeah, it's not really.
so, if you wanna come and actually listen to him, there's two here on his chest.
One right here,
And
and
there's,
there's like
is there one?
another one over here, here, and then I think
Yeah, there's a couple.
I could hear. Yeah, I could hear it over here.
Okay.
as well.
So, here and here, these two in the upper chest, these two, should be, okay, so anywhere you see that little marker, if you will, would be a place to listen. So
Are we
maybe,
done with these?
maybe this thing will,
That's,
Leave it dirty.
under resources in the Discord, if you guys are in it, there's a couple apps in there. One's called EMT Trainer. There's a whole section on the sound. So if you're using earbuds on your phone, you just listen to the sounds. You'll hear Strider, all that stuff. Might be good before Sunday.
now remember,
Play the audio. Check.
Now remember the different locations of the sounds. The larynx is the cutoff point for upper airway sounds versus lower. So that's one of the other things you need to kind of pay attention to, okay? So one of the things that we need to remember, breathing as well as circulation, we're checking for rate, quality, and the character of their breathing and circulation. So you've had time to do breathing. Does everybody understand how to count and get a respiratory rate?
Take the beats over 10, 15 seconds. Or, no, we're doing
Kind
30
of for a whole
seconds now.
minute.
You can do 15 if it's regular.
Okay, 14 if it's regular.
Definitely if it's irregular, you need to count for the full minute. Now, here's the thing. you need to train yourself on how to count, and I say that very sarcastically to a point where if someone's hyperventilating, they can be hyperventilating about 50 times a minute. You're gonna have to keep up with them. Not to mention little infants who breathe about 60 to 80 times a minute. So again, it's easy for adults because, you know, we got that great range right there on the board. But when you're talking about someone who's hyperventilating or an infant, you're going to have to learn how to count fast within that minute. Okay, so does your little videos have a trainer on breathing
I'd
rate?
have to go look and if
Go
it
look,
has like
okay.
infant specific, I'd have to check.
Because that's going to be important. Okay, so are we comfortable with breathing? How to assess breathing? How to count a respiratory
Give
rate?
us your children.
That's what I was gonna say.
Yay!
He is my
Awesome.
kid.
All right, great.
Oh, there you go.
Yeah.
Yeah,
Just
he,
for-
he
I
would
can
love
bring
it.
all. Yeah, he will.
Oh, you make it sound like you got a whole like litters and all the way.
That's free, so.
Oh, oh wow.
So if we break one,
Woo!
right?
So,
You got backup.
From all ranges, 9 to 2, so,
That's
just
really
pick which
good,
one.
actually, yeah.
so again, not trying to be funny, but take
Bring my
Be vitals on them?
no, take advantage of the resources y'all have, okay? Each other as well as the children, because again, if you can train now, then by the time we hit the pediatric chapter next semester, then you're gonna be actually ahead of the game. So utilize the resources you have available. If she's got all ranges, and how old is yours? 3. So she's got a 2, 3, and a
4.
4,
And
and 9.
I have 9, 4, and 2.
9, 4, 2, 3, 2, okay? So you have a range, so take advantage of the resource, okay? Now, do we need to go over how to properly count to get a respiratory rate? Yes, okay. So, Errol, come right here, sir, be my patient, grab a chair, either that one or your own, doesn't matter. So one of the things that is very difficult to do is actually count a respiratory rate and not do this. Because when we do that, we bring attention to what we're doing, and then he's going to change his respiratory rate. It's true. It happens all the time. Happens all the time, does it not? Okay. So you're going to have to develop a technique in order to learn how to count someone's respiratory rate without making it obvious.
Distract them one way and have your partner behind.
Okay. There's a couple of things you need to take into consideration. Is one, if they're breathing normal, but you not necessarily can see it through their clothing, that's going to make it very difficult for you to count. Some people actually, hey sir, how you doing and everything. Okay, so watch carefully. My watch is that way for a reason. Okay, sir, I'm just gonna say, you mind if I just kind of touch and talk with you? So now I'm marking my thing while I'm talking to him, but I'm gonna kind of do most of the talking for that 15 seconds before I allow him to answer. Because now I've got a respiratory rate. I'm actually feeling chest rise and chest fall. So while y'all are out at y'all's little outing and things like that, or whenever you decide to go out and sit at a restaurant to go eat and things like this, what I want you to do is I want you to kind of scan the area of the crowd, and then what I want you to do is I want you to pinpoint somebody and count their respirations from a distance.
This is getting weird.
People watching? Shoot.
But again, I know, right? Okay, people watching, okay?
What do you think college was about? Just sitting
Yeah,
there?
no, right? Just okay. People in the student center, in the library, at a restaurant, wherever you're out, remember that you count for 15 seconds if it's regular. So you'll know by the first 2 if it's regular or not. So just kind of glance out and then come back. You know, kind of not be like on them. I mean, unless you're like at a significant distance, and they're obvious that you can see this going on. Okay. I'm sorry, I'm just gonna throw this out there, I'm so sorry, but big busted women are the great ones to actually look at, because again, that's what you see moving.
I
mean,
feel
I'm
like
not trying
in
to
this day and
be,
age, I feel like some of us should.
We're gonna get in some trouble.
Yeah.
I know, but I'm just saying, okay? But the
My
bigger
teacher said it
busted
was
women,
fine.
actually, you can see their chest pretty obvious through their clothes that they wear, that you can actually see this. Now, on someone like Joseph or Amon, even Errol, okay, the fact that you're cut that sometimes makes it very difficult because of the fact their range may not be normal, but you know, you're really gonna have to focus. Okay, so this is how you train to count respirations from a distance. Again, you have to train yourself. Practice makes perfect. Take advantage of the time. I used to have a blast at the beach, you know, because I'd just sit in my chair and just kind of look around, watch the kids play and things like that. And then, you know, those that are sleeping, you know, on their, you know, bellies are on their back, you know, and they're soaking up the sun. Great people to like, okay.
Sir, you may have respiratory problems.
I know, right?
Hey,
But take advantage of the situation, as funny as that may seem, okay? So, when you're doing respiratory rate and you're counting rate, okay, if the rate or the rhythm is regular, then I'm going to count for 15 seconds. That's how come you need to watch with a second hand. Isn't that what you call that thing? Second hand, thank you. Because once I target a starting point, then I need to count 15 seconds later, then I need to count his respirations. Each respiration includes an inspiratory and an expiratory phase to be counted as one. So however many I count in that 15 seconds, I will then multiply by 4. Now I have his respirations per minute.
So it's good with an analog that just points out, you know, 12, 3, 6, and 9.
Yeah, that'd be the easiest. Then, you know, 5, 20, you know, things like
Yeah.
that. So make it easier for yourself, okay? Now, for those of you that have the smart watches and the digital watches and the things that you have to constantly do this in order to get this face to come about.
geez.
That's just a lock screen.
Yeah, but some of them you actually can keep it
Oh, yeah,
where
yeah.
it's a face like that. So my last class, they were constantly doing this number and you're losing spot. Just be mindful that here, before you are cleared, you're going to do your National Registry checkoff, which will include a medical assessment, and that clock right there is not going to be available.
Well, we can use a watch.
But you can use a watch. That's what you're supposed to have. At clinicals and stuff, you need to have a hand with second hand. Okay. So again, so if I'm counting his respirations, okay, I know, dude. I know.
More money, more money, more money, more money.
Now, if you have a digital watch, okay, which
I gotta stop, but I gotta do that.
yeah,
I
okay.
get something else.
Like,
You need someone
Sorry,
to
man.
That's why I was like,
Right.
what?
You know, but I mean, again,
It's
technology,
$15
you know, is improving. You like to have the newest stuff. I got it, but you know, I'm old school, and okay. But again, you have to at least get something that's got the second hand that you can count, or you know, if that particular one had the seconds on it, then you could do it that way. But you know,
No, it does.
you have the seconds.
There
There
you go.
So if
you
it
go. So
says
you can
the
do it that
seconds,
way.
it's safe to use a
But
digital
again,
watch.
it'd be easier to start on
Yeah.
either 12, 3, 6, or 9 in order to count. And so that's what we're looking for. So we're looking chest rise, chest fall. We're looking for inhalation, exhalation for that one that we count. Okay, so you have to kind of pay attention. So everybody stare at him. Okay, just breathe normal, please. And then we're going to time it. Count. Begin now. Okay, how many did you count? Everybody get 5? Okay, so he's breathing how many times a minute? 20. That's how we do respiratory rate.
That's normal.
Okay, just like, okay,
On
this is,
that high end, man, you might want to work out, but
Hey, no, I work out.
I know, right?
I know, I need to.
Okay. So this is respiratory rate. Circulatory rate or pulse rate is no different. It's just now we're having to palpate a radial pulse in order to determine how many beats per minute his heart is contracting. Now, same concept. 15 mark, count for 15 seconds if it is regular and multiply by 4. If at any time it turns irregular during the 15 seconds that you're counting, you need to count for the entire minute. Okay? Now, pulses. There are several different locations that we check for a pulse. Everybody's been to the doctor. They always go back here at the wrist. What's the name of this pulse called? Radial was the one that we check in a pediatric or infant. Brachial. Okay. These are considered peripheral pulses. Central pulses would be right here at the neck, which is called the carotid, and the one right here in his groin femoral. Then we have 3 separate ones in the leg. Okay, one behind the kneecap, which is called the popliteal. And then you have the one that's on the top of the foot, which is the dorsalis pedis. And then you have the one at the ankle, if you will, behind the ankle, is the posterior tibialis. These are the pulses you need to know, and you need to be able to separate them from central pulses to peripheral pulses. You will see that on National Registry. Okay, central pulses here versus peripheral. Okay?
So legs peripheral too?
Yes. Okay, this is considered central, just your trunk, if you will. Okay? Make sense? Okay? So again, just like with breathing, there's 3 things I want to know about his pulse rate, or his pulse in general. One is the rate, the quality, and the character. The rate, what is it? Okay, the quality is it regular or is it irregular? The character, is it thready? Is it bounding? Is it pretty, solid, if you will? This is what I'm looking for as far as the character is concerned. You will know thready pulse when you feel it because you can barely feel it. Okay, you're having to push down a lot more harder to feel the pulse versus someone who's very calm and you can just gently put some pressure right there and wow, it's there. Okay. Now, here's the thing: do not ever check a pulse with your thumb. Don't put your thumb on him anywhere. Thumb's got its own. Okay. So are you actually feeling his or are you feeling mine? Okay. So it's always a couple of fingers. Now, a lot of people have problems finding other people's radial pulses. So this is what you're going to be doing now, is that you're going to check each other's radial pulses on both sides. One of the things that you have to understand about anatomy and physiology, wherever there's a major bone, there's an artery and a vein and a nerve that run with it. If you're having trouble, especially those that are a little bit more fluffy and got a little bit more meat on them, it may be a little bit difficult to find, but the pattern will always be the same. If you rotate their hand out and their forearm outward, remember that the radius is on the thumb side. So if you will follow that to the junction of the wrist and go about 2 fingers above, you will find the radial pulse. Okay, mine's pretty obvious because it's like bounding right there. Okay. So this is the proper way to find the radial pulse. Now you can either check it this way or you can check it the opposite way, like this. Okay. But again, you always want to check on the same side that you're on. You never want to kind of cross over because the normal gist would be to kind of grab him with your thumb in order to find. So we always want to check things on the same side of the patient that we're on. So if I'm checking blood pressure, his blood pressure will be checked on this side. If it's his pulse rate, it's on this side. If it's his respiratory rate, it's on this side. If I check for breathing and auscultating his breath sounds, it will be always on the same side. The only time that it's a little different is the fact that when we check pulses, we want to ensure that they are bilateral, which means that you may have to kind of shift position to in front of your patient and actually grab the wrist at the same time to determine, are they equal? So I'll throw a question out there to you. What if one of them's not equal as the other? Now what? What does that tell you?
It might be a problem.
Problem somewhere. Like this one's like more, you feel it, it's pretty bounding, whereas this one's pretty thready. You're like, what's going on here? Okay? So this is what we're looking for. We need to know if they're equal. Okay, one of the things that we check for stroke is we check for both sides of the body peripherally to ensure that things are equal. Because if not, that tells me that he's got something going on up here. Okay? Because again, brain function controls everything else. Okay? Does this make sense? So practice on each other. Check and count a pulse rate on everyone. So just go find your partner, find whatever, count your pulse. Remember, don't use thumbs. Come on, take your thumb off.
Yeah, you come with us.
Both thumbs.
Okay.
Yep, both thumbs.
It's not there. Beats by Dre. Come on over.
Yeah, wait.
Yeah, this one's actually a little bit harder.
Yeah, I found out I have more Muslim mouse on one side than the other. No, I'm just, you know, I
Yeah.
complimented myself here
Yeah.
a while ago. So I was wearing a brace, so like I was pulling the same weight.
Yeah.
I was pulling the same weight on both sides, but this had the brace supporting it, so it probably didn't feel it as bad. So now I'm back off the brace, so it'll even out sooner or later.
No, you could. Yep. No.
Right there. Oh. There you go.
Hey, dude.
Logo.
Dude, that's funny.
It reminded me of the tattoo that J.R. Smith got, the Supreme on
Oh,
his
yeah,
calf.
yeah.
Logo.
Yeah, why not? I feel, yeah, I feel.
They just bouncing.
Yeah,
on
guys
the
are,
perfect.
guys are.
Of course, like,
Oh, really? Because they were struggling to find mine.
no.
There it is.
Yeah, the cards.
Didn't change it.
This one?
It was pretty easy.
Yeah. Yeah.
Oh, we're dirty.
Okay, is everybody okay with that? Everybody know how to find the rate,
You
how to find the
disgusting
poles and stuff?
Pretty good with that. I should have listened.
We legit talked about
Yeah, I
this
know.
yesterday.
I know.
You've been on it the whole time. Now you ain't gonna make it.
Okay, so,
He's been looking at me this whole time.
Yeah. Just
when I
the
talk about the fact that you are obtaining baseline vitals in the primary assessment, this is what I'm talking about, and we're gonna add, so there's a couple of things under circulation that you need to check, not only the rate, the quality, and the character of someone's pulse. We are also going to assess their skin color, temp, and turgor.
What's turkey?
Like the water, like if they're clammy or not?
I'll show you in just a minute. Okay, everybody kind of take a moment to write that down.
Oh, no, you good.
So again, when we start talking about patient assessments, this is what we're basing a lot of things off of. And then, so that you can see the trauma assessment side by side with that. Well, here, let me just go ahead and give y'all the set. Okay, here's your trauma assessment.
Which one is your favorite, medical or trauma?
I'm all about a medical patient because a medical patient challenges you more than a trauma patient. That tests your skill a lot more than a trauma patient. Trauma patient's pretty cut and dry,
Yeah, there's lots.
if you will. Not,
Believe.
not trying to, be ugly, but yeah, trauma's pretty cut and dry. Whereas medical calls, especially if you have a patient that's got multi-system failure going on, you have to think.
That's true enough in the military. It's all about trauma unless you're dealing with like a contractor who's, come overseas with some conditions. Thought high altitude would be a good idea.
You know?
Yeah.
So let me give y'all the set. Y'all need to keep these with you, start reviewing them, go over them. And again, we're gonna hit all of these skills in class. And now's the time to start learning them, okay? Because by the time next semester is over with, y'all are gonna be very proficient in this. And I keep telling y'all that this is a very, okay, so let me make the statement now that I see Michaela's shoes. When you come to lab, you need to either wear tennis shoes or closed-ended shoes. You need to wear get dirty clothes, because when we start patient assessments in the next week or so, well, we kind of actually started now, but we're not going to be confined to this room. We're going to be outside in the ditches and cars, up staircases, up the staircase here. So be prepared to come outside of this room. So you may be in the grass, you may be in the grassy knoll, but we're going to put you in some dirty places. So that's one of the great things, even though COVID's got everything kind of jacked up, if you will, we're going to be outside playing. And this is part of the reason why a lot of the nursing students hate us, because we get to go play and they don't. So I will tell you this. Next semester, we're going to do a mass casualty incident here, in which we are going to incorporate the nursing students, the practical nursing students, the respiratory therapists. We may even get sonography. We may get the radiology students involved. So this is going to be a big to-do. Okay, it's a lot of fun whenever you can kind of see the process begin from start to finish. There's one more that I will need to get to you.
That's the state one?
That's the state one that they require, and believe me, you're going to know that one at long spine board. Okay, so the first 5, if you will look on a medical assessment, you will see the first 5 there somewhere. Okay?
Oh, here you go.
And the 4 things and everything on.
So, if you were to break this down, and again, if you look at the very bottom of the page where it says vital signs, that is considered a secondary assessment. I'm teaching you to get baseline vitals up in the first 5 because you've got the majority of it in A, B, and A and B and C. The only thing that you're missing is the blood pressure. So if you were to incorporate, which I'm teaching you to do, the blood pressure up top in the first 5, you will automatically have their baseline vitals. So when you look at this, okay, takes and verbalizes appropriate PPEs. Okay, you should know what type of PPEs you should have. Okay, so here, let me give you my PSA announcement. I don't know if y'all have ever seen this on TV. I don't know if y'all have ever seen this in real life, but I think it's quite comical to see people as well as EMTs and paramedics in their vehicle driving with gloves on. Has anybody seen that? No. Okay.
No, I've seen that, but it's, yeah.
Okay. You feel where we're going, okay?
Yeah.
I understand that we live in a non-sterile world, especially in our world, okay? Let me explain what happens when you get into the front seat of that vehicle and you have gloves on because you're racing to a scene, because you want to be prepared. I want you to think of all the germs that I'm going to collect. Ready? Steering wheel. Woo, 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 okay, the knob that you changed the sirens for, okay, I just added some more germs. Now I'm putting it back on the steering wheel. Opening the door, now I've just added some more germs. I closed the door, that's more germs. Guess what's on the back of these doors?
Germs stuff.
The exhaust from your truck. How many times do y'all pull up behind an ambulance and it's as black as it could possibly be? That's the exhaust coming from your truck. Then now I'm going to use all the germs from the front of my cab to the closing of my door. Now I'm going to open up these doors that now have all that exhaust. And then what I'm going to do is I'm going to put all my equipment on my stretcher and then pull the stretcher out that I just now contaminated. And then I'm going to come up to a patient with dirty gloves on and go, hey, can I help you?
What if you peel off that top layer then? Because you said wear extra gloves. So if we peel off that top layer, we're good to go.
But think of everything that you've just contaminated, including your stretcher. Do not put on your PPEs or do not don PPEs until you're approaching the patient. Hey, ma'am, how's it going? Great, all right. I want to decrease the amount of germs that I'm bringing to my patient, and the only way to do that is if I'm coming up on her, and the only germs I'm getting is maybe from my pocket, from the glove, you know, because I used to carry like the BDUs, and I had a bag, pocket full of gloves. That's where I got my gloves from. They were nice and handy, you know. I didn't have to worry about pulling out a glove, closing the pouch, putting them on. They were like right here. I'm trying to prevent as much germs to my patient, especially if they're already sick, or let's say you don't even know that they're immune compromised. You have just now exposed them to more germs than need be. Okay? PPEs. So, don on your appropriate, as you're approaching scene safety, you're looking at the patient and trying to get an idea, this is when you're putting on gloves. You should already have your safety goggles on. Okay? Determine the scene size up. Number 1, here we go. Determine scene and situation is safe. That's number 1 of your first 5, correct? Number 2, I want to know the nature of the illness, mechanism of injury, the number of patients, additional resources, consider stabilization of C-spine. Okay, additional resources, what else did I put on here? Okay.
I guess they're just wanting us, if I'm at a motor vehicle accident, I want to immediately assume, hey, there's probably cervical spine injury. So maybe that's what they're going for, I don't know.
As far as what goes?
But having, right, the scene size up, consider stabilization of the spine.
Then that's considered trauma, not medical.
Yeah.
So don't be surprised if you miss that on your test, that's fine. Because again, you need to get 84% or higher, so that would be that you can miss like 2 or 3 points, I think, okay? So a lot of people, and I have me and other program directors, other technical colleges sent National Registry to reconsider that, because if we are considering stabilization of the spine, then that turns that medical call into a trauma call, not medical. Okay, now, there are instances in which a medical emergency is what caused the trauma. Okay, that's still different because we're still going to initiate the trauma first, and then we're going to kind of backtrack and ensure that we've covered all the medical stuff. But if we're considering stabilization of the spine, then that is no longer a medical call. So, okay, this is number 2. 1 is you determine the scene situation is safe. Number 2 is MOI, NOI, number of patients, additional resources, and stabilization of the C-spine. That's number 2 of the first 5, is it not? Number 3, I'm sorry, move down 1. Verbalize general impression, level of consciousness. That's all in number 2. Number 3, assesses the airway and breathing and circulation. 1, 3, 4, and 5. Now, if you'll understand under assessment of circulation, you're doing either skin color, temp, or condition. Okay, this is all under circulation. And we're going to add blood pressure and CRT, and I'll explain those in just a second. So you see how the first 5 is there. Then you have history taking, past medical history, and all that, and then you begin your secondary. This is what I'm talking about. The first 5 will never change except for CPR and certain trauma cases. So after I have assessed, sorry to borrow again. Okay, after I assess the circulation and stuff, notice that I'm already here. Do you notice that my palm's already touching her skin, right? But this is not the portion that I'm going to use in order to check her skin temperature. I'm going to actually remove my glove, or halfway remove my glove, and use the back part of my hand to feel if she's hot or not. I know whenever we were kids and your mom checked her, man, you got a fever? Okay, wrong. Okay, sorry, Mom. Okay, okay. Do y'all do it to y'all's kids too? Hey, hon. Okay, no.
She
Okay.
go like this.
It's normally like this. We want to feel on the back side of our palm. We want to check right here. Okay, we're checking peripherally. Told you I was going to get personal, right? And I want to check centrally. This is how we check skin color temp. Okay, color I can see. Okay, I'm a little darker than her, so. Okay, I'm checking for color. Is she turning blue? Is there different colors to her skin I need to be paying attention to? Okay, now, I'm already here. Okay, take it off. All right, yeah. Okay, come on, good. Color's normal. Okay, now, CRT stands for capillary refill time. Okay. A normal capillary refill time is less than 2 seconds. Can you see that with the bag there? No.
Thank you.
Sorry. You keep going. Okay? Capillary refill time is less than 2 seconds on a normal patient, on a normal person. We check that, Michaela, give me your hand. We check that by blanching her fingernail. So if I was to blanch her fingernail, you would notice that it would turn white. And then when I let go, you should count 1/1000 and count how many seconds it takes in order for it to come back to normal. That is capillary refill time. Now, let's say that we have somebody with fingernails on that's got, what do you call that stuff? Nail polish, okay, or fake fingernails. Okay, am I really going to be able to tell that? No, not so much. There are other locations to determine that. So I can turn her palm over and I can blanch her palm. You see how it blanches and then comes back to normal? Okay, that's another area. On pediatrics as well as on infants, we would kind of blanch the bottom of their foot, top of their hand, and the palm. We're looking for some type of change in that response. That is capillary refill. Remember what happens in the capillaries and why this is so important. This is the reason why that's important, because if I was to blanch my fingernails and it comes back to normal, that means I'm getting perfusion to my fingertips, which means it's got to go all over this to get there. That means my heart, the cardiovascular system, in lieu with the respiratory system, is getting perfusion to my fingertip. It becomes an issue when I sit there, hey, whenever I do this and I'm counting 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, oh my God, 5 seconds. That tells me that there's a delay for whatever reason. Tracking? This is CRT. And then we're going to check blood pressure. Now you have baseline vitals of your patient upon first contact. You're not having to wait later on to get a blood pressure for a complete set of vital signs. You've already got it.
Did you mean to put the I right there?
The I.
It's a slash.
Oh.
Blood pressure
Oh, I was
B
like,
slash
what?
P. I'm
I put
sorry.
an I.
Yeah.
Sorry.
I called it the bip.
Yeah, I was like, where's the bip?
I was like, uh-oh, we got to learn something new today.
Oh, I
Hey,
got
that
it.
bip.
Yes.
Does that make it better? I'm sorry.
I'm over here making fun of you.
Right.
We're gonna need some puppets in here.
I was like, that is a
Nah.
That's a bip.
Puppets are weird, man.
Okay.
Clowns, bro.
Okay,
Alright,
so
that's cool.
So if we were to check blood pressure, again, now you have baseline vitals. And again, please understand, when you do a National Registry checkoff with a proctor, they're not going to expect you to go in order. You have to make this assessment your own. But I'm telling you, I'm teaching you that the first 5 will never change. I don't care what type of call you run. You will do this in order. The first 5 will never change, except for CPR and trauma cases, okay? Everything else is at your discretion on where you want to plug that in. So if I get a blood pressure and it's up here in the primary survey, they're not going to dock you because, well, gosh, he did that up front instead of down below. They're not going to dock you for that, okay? The purpose of this particular assessment is to get you into a systematic approach of how you approach your patient every time. Not once in a while, not on occasion, every time. Now let me tell you the importance of it as far as the number 2 factor. I'm teaching you on how to be a well-rounded EMT. That means your patient care and your treatment has got to be on target, and then your documentation's got to be on target. So guess what your documentation is now going to include? Everything that is on this list. So if you have a systematic approach to how you do your patient, you're going to be doing your documentation. Okay, first 5 never change. God, I hate that one. Okay, this is what you're going to be writing. You're going to be doing it. And then by the time you make this your own of how you want to do your assessment, your secondary assessment, then as you're writing, this is what's going through your head to document. Now, there's always an exception to the rule. I'll give you an example. The first 5 that we are checking for are what we consider life-threatening emergencies. If I get to a patient, it's just me and my partner, and I have a breathing issue in which I'm constantly having to rescue breathe for my patient with a BVM, guess what? I'm not going to get to a secondary assessment because I have a life threat that needs to be addressed. And if it takes me from the time I see her till the time I drop her off at the doctor at the hospital, then guess what? I'm not going to stop a breathing problem that requires my attention constantly to do, hey, let's see what a secondary assessment looks like. We're not going to do that. How I document that is just the way I said. Okay, airway was opening clear at the time, breathing 4 times a minute, required positive pressure ventilation with a BVM, rescue breathing once every 5 to 6 seconds, did not have secondary help, did not complete a secondary assessment because I had a life threat that needed my constant attention until I dropped that patient off at the hospital. That's how you cover your booty when you document. Because that's exactly what happened. I had no additional help. Firefighters, they were on a fire call. All my other units were not available. It was just me in the back of that ambulance. So guess what? I can't do anything else. Now, can I visually and use my other senses of trying to look? Well, if they're fully clothed, that's not going to tell me nothing either. Okay? And I'm not going to go 1, 1,000, 2, 1,000, 1, 1,000, 2, 1,000, and then do other things. This is my primary purpose now. Does this kind of make sense where I'm going? I'm teaching you to be a well-rounded EMT. Your patient assessments and your treatments got to be on target as well as your documentation. Now, when we start talking about legal medical and we start talking about documentation, we're going to be doing some documentation exercises and things like this. But I'm telling you now, everything that is on this list, as well as a trauma assessment, has to be in your documentation. Pay close attention to what I'm saying. Do not pick up bad habits from other people in the field. You have worked long and hard for the numbers you earned, and if you decide to take shortcuts, that's what's going to hem you up. Because I'm here to tell you, working 18 years at Grady, I've been to court many times. And I can tell you that what you didn't have documented, those attorneys are going to rip you apart. Because you know what the first thing they're going to do? They're going to pull a National Registry checkoff, and they're going to go line by line, box by box on your documentation and see if they can't pick you apart before they ever get to your treatment. Because if they can make a jury of your peers look like you're incompetent, guess what? Your company, as well as you, might as well just open up the checkbook and just go ahead and write them give them a blank check. So, I'll give you a prime example. Whenever I first started in EMS, luckily I was an EMT. I was called the ambulance driver, and it was great. We're always called that, but hey, we're called docs out there in the field as well. So, okay, so I first got into the medical field as an EMT. I'd been on the job for maybe 3 months, and the partner that I was with, I'm sorry to say, was a prick. He didn't want me to do anything but drive the ambulance, maybe help him with the stretcher in order to put it in the ambulance. About that was about all my job. He didn't want me touching paperwork, he didn't want me documenting, he didn't want me doing jack. Okay, but little did he know that on every call that we ran, I wrote down and made my own documentation and kept it in a book. So we had a cardiac arrest. Actually, the lady was in respiratory distress. Very significant. Tripoding, sweating, all the classic signs that you would imagine, if you will. Respiratory distress, and then she went into cardiac arrest. He wrote his documentation, and I did mine on the side, as I always did. 6 months later, we were called to court. We were subpoenaed to come to court. They called me up there on the stand first, and they started drilling me, trying to get me to admit that I did something wrong. I said, sir, I said, you can ask my partner, you can ask any other partner that my partner has had, and I'm not allowed to do anything. I cannot take vital signs, I cannot assess a patient. The only thing I'm instructed to do by my paramedic partner is to drive that ambulance and get him safe to the scene and safe to the hospital, and clean the truck and work on the stretcher, or help him with the stretcher. That's all I was allowed to do. Okay, get off the stand. And then they put my paramedic partner up there. And I was just going, so the very first thing they did was they pulled his report from 8 months ago. This is another reason why documentation is so important, because this is the only thing that you're going to see 8 months, a year, 2 years, 3 years later that's going to jog your memory as far as what you did and what type of call you went on. And I'm telling you, they went box by box, line by line, asking the paramedic that was sitting on the stand, sir, is this box right here, the date, is that supposed to be filled in on every patient care report that you fill out? Yes? Okay, so why did you leave that blank? Do not say, I don't know.
Yeah,
Bad
don't say.
juju. Can you explain why this date is not entered on this patient care report?
Do we get, actually that's a good point, do we get any counsel, or they just get to grill us all day?
No, you can get counsel,
Yeah.
but again, you better be very careful on what you're, okay,
On the
and
emergency
ma'am, are you
response.
supposed to sign this right here? Is this supposed to be your signature block? And so why is that left blank?
Got another call. That's all I'm saying. Got another call. Got another call.
You see where I'm going with this?
Did that.
So they took the very front of our page, and back in the day, we had a bubble form we had to fill out, which included all the dates of dispatch, arrival time to the patient, when we left the scene, when we got to the hospital, when we went back in service. All of those times are in there. The attorney made him look incompetent on just the basic necessities on how to fill out a patient care report, and then when they turned it over to see his treatment plan, they ripped him to shreds. There's two types of EMTs and paramedics and advanced EMTs that are out there in the field. Those that have been to court and those who have not. Do not allow, I don't care how old your partner is and how many years they've been in the field, do not ever take shortcuts on documentation. Because I'm here to tell you, that partner is not whose license is going to be pulled, it's going to be yours. You've worked long and hard for it. Don't let someone take it away because you took bad advice. You don't believe me? Go ask a doctor in a hospital. Go ask a nurse in the hospital as far as why the importance of documentation is so important to maintain, to keep a systematic approach. Because again, if you do your patient care that way, that's how you're gonna document. Don't leave anything out, okay? More information, here we go, about crime scenes needs to be in your documentation. We talked about that today. Crime scene is going to be very important. What did you see? What did you move? How did you get to the patient? How did you get that patient out? This is all this, you're gonna spend some time with some documentation, okay? I can't stress it enough.
If our party member, like the paramedics, they gonna sign it, right?
You both are gonna sign it. It's just not your paramedic partner.
So you gotta take the time to go over their report. Make sure you verify.
Because the thing about it is that you may have remembered something that Michaela did not, and she's the paramedic. Hey, I remember this being there, and we moved that, you don't have that document. Okay, well, we need to put that in there. Now, here's the thing with documentation. Any patient care report that you turn in, you only have 24 hours to put an addendum to it before you cannot do it. So if there's something that you recall later, something like that, you have 24 hours from the date of that call to add an addendum to it. After that, you cannot touch that patient care report, not even with a 100-foot pole.
When are you supposed to actually put in paperwork? Because I'm assuming you can't exactly do it while you're just driving around.
No.
Okay, so here's the thing. Upon every patient that you transport to the hospital, your documentation and so forth needs to be complete before you leave the hospital.
Yeah.
Oh, before, okay, yeah.
So you have time at the hospital while you're standing up against the wall with your patient to fill out your documentation.
Just gonna ride along.
Yeah.
Maybe do it in the back.
Okay, so again, documentation is gonna be important. All right? Do you have any questions about what we've gone over today?
Productive day.
Okay, so, here's the thing, okay, when y'all have y'all's little, is everybody in the study group, everybody here, or is it just like a couple of y'all?
This is the study group. I'm a discipline.
Okay, so,
It took me a while. Wow.
while y'all are studying for your exam for Tuesday, if you should have any questions, let me know. I can actually come to y'all, meet y'all for coffee or whatever, and kind of discuss things in order to kind of settle your mind about chapter 10, okay? So please don't hesitate, just all I ask is do not text me or call me past 9 o'clock. I do have a life outside of work. Okay. All right? Any questions, anything I can help you with, anything that